Welcome. This is the Trauma Informed Care Training. This presentation, which provides training for F699, Trauma Informed Care, and F656, Comprehensive Care Plans. For detailed information about these two new requirements, please refer to Appendix P in the State Operations Manual. In this presentation, I will provide you with an overview of the requirements, the intent, the interpretive guidance, and the investigative protocol for F699 and F656. In addition, I will highlight where you will investigate concerns regarding F656. Under F699, trauma-informed care, the facility must ensure that trauma survivors receive culturally competent care according to the residents' experiences and preferences to avoid triggers leading to re-traumatization. Let's discuss the intent of trauma-informed care. This requirement ensures that facilities provide care to trauma survivors that meets professional standards and are culturally competent. In addition, it ensures the care that facilities provide accounts for the experiences and preferences of the residents and addresses the needs of trauma survivors. In Appendix P, we provide definition of key terms. Here are two terms that I would like to highlight. Trauma results from an event, a series of events, or a set of circumstances. It can be physically or emotionally harmful or life-threatening and has lasting adverse effects on an individual's functioning and mental, physical, social, emotional, or spiritual well-being. Trauma-informed care is an approach to delivering care that involves understanding, recognizing, and responding to the efforts of all types of trauma, recognizing the widespread impact and signs and symptoms of trauma in residents, avoiding re-traumatization. Studies have shown that 70% of adults in the United States have experienced some traumatic event, and there is a direct correlation between trauma and physical health conditions, professional standards, and are culturally competent. Here are just a few examples of individuals who would be considered trauma survivors. Using a multi-pronged approach to identify a resident's history of trauma and cultural preferences, facilities should ask the resident about a history of trauma, observe the resident, use screening and assessment tools, and obtain social history assessment. After the facility identifies who their trauma survivors are, the facility must identify what are some of the triggers that can prompt a recall of the previous traumatic events. Even though triggers are highly individualized, there are a few common triggers that we should keep in mind, such as sight, smell, sound, and touch. For instance, the triggers for a survivors of abuse may be an object, perfume, body odor, tone of voice, or physical touch. Importantly, facilities must identify triggers that may cause re-traumatization of the resident. It is important to know what culture is and what culture competency is. Culture is a concept, beliefs, norms, and values of what and how people view the world. Cultural competencies, also known as cultural responsiveness, cultural awareness, and cultural sensitivity, involves valuing diversity, conducting self-assessments, avoiding stereotypes, managing the dynamics of difference, acquiring and institutionalizing cultural knowledge, and adapting to diversity and cultural contexts in communities. The demographics of the facilities are changing in these days. In addition to racial and ethnic diversity, the facility must also accommodate religious preferences, sexual orientation, and gender identity. Therefore, surveyors should use the facility assessment to identify resident populations having unique cultural characteristics, such as language, religious or cultural practices, values, and preferences in that particular facility. When determining the compliance of F699, surveyors should focus on the four key elements listed on the slide. Did the facility recognize a resident's cultural preference, past history of trauma, and triggers that cause re-traumatization? Did the facility provide interventions that are culturally competent and are trauma informed? In the facility failed, If the facility failed to do any of the key elements of noncompliance from the previous slide, surveyors should consider the negative outcome to the resident and the facility interventions to address the resident's history of trauma. Because of the potential for psychosocial harm, noncompliance at F699 should generally not be cited at a severity level 1. CMS provides examples of severity level 2, 3, and 4 noncompliance in the interpretive guidance for F699. For detailed information, please refer to Appendix P. Besides looking at F699, trauma informed care, CMS also adds a new requirement in the F656 Comprehensive Care Plan, which is culturally competent and trauma informed. The intent of this new requirement is to ensure that each resident's comprehensive care plan includes approaches to address the resident's cultural preferences and reflects trauma informed care when appropriate. If concerns are identified related to how the facility addresses cultural needs and preferences, the surveyor should review the resident's care plan and determine if the care plan describes the resident's cultural preferences, values, and practices, and includes approaches to meet the resident's cultural needs. For concerns about how a facility cares for a resident with a history of trauma, review the care plan to determine if it describes interventions that take into account the resident's experiences and preferences to eliminate or mitigate triggers that may cause re traumatization and psychosocial harm. When care planning to address a resident's history of trauma and or resident's cultural preferences, there should be evidence that the facility collaborated with other trauma survivors, family, friends, and healthcare professionals to understand the resident's trauma experience, which would include finding out triggers that may be re-traumatize the resident and developing interventions to help avoid these triggers. With regard to care planning to address cultural needs and preferences, nursing home staff should consider aspects of cultural preferences, which may include communication, food preparation, clothing preferences, physical contact, or provision of care by a person of the opposite sex, cultural etiquette, voice volume, and eye contact. The tags listed here show where to investigate concerns related to culturally competent care and trauma informed care. Refer to F656, developing and implementing the comprehensive care plan for concerns related to care planning, addressing cultural needs and preferences and or needs related to a history of trauma. For concerns related to resident outcomes or potential outcomes from how the facility provides culturally competent or trauma informed care, refer to F699, the new tag for trauma informed care. For concerns related to the facility's nursing staff's knowledge, competencies, or skills in providing culturally competent and trauma informed care, refer to F726, the tag for competent nurse staffing. And lastly, if there are concerns related to the treatment and services needed for or provided to a resident with a history of trauma and or post-traumatic stress disorder, these concerns will be investigated at F742, the tag for treatment and services for mental and psychosocial concerns. In summary, there are new requirements related to culturally competent care and trauma informed care, which can be found at F699 and F656. New key terms have been defined. CMS has developed new key elements of noncompliance to help surveyors determine when to cite deficient practice. Surveyors will also need to determine the level of severity and new examples that have been provided in the interpretive guidance. Other requirements related to culturally competent and trauma informed care can be found at F726 and F742. For questions about trauma informed care, F699, please send them to the DNH triage mailbox at dnh_triage@cms.hhs.gov. And thank you for your continued efforts towards our shared goal in providing quality care to America's nursing home residents.